An important aspect of the relationship-based care model is family and patient-centered care. Policymakers have recently highlighted the importance of patient experience and satisfaction. In the ICU, most communication is done with family members due to the critical state of our patients, and those same patients are relying on their family's perceptions and information when filling out surveys on satisfaction. ECMC's April 2016 Press Ganey report on satisfaction with communication shows we are at 74.1%, below the average benchmark of 82%. The communication I have personally received from families has always been related to how confusing and stressful our waiting room process is. Our visitors are sent to the ICU waiting room with no information other than what room number their family member is in. My aim for this change project is to improve and maintain Press Ganey communication satisfaction scores to 90% within 6 months. This will be done by improving communication, comfort, and information provided to families in the trauma ICU waiting room. Information is often the most significant need for families of critically ill patients. This is also the lowest met need. Being a family member of a critically ill patient is stressful, and lack of information can spiral this stress into panic, shock, fear, anxiety, frustration, anger, and overreaction, making it impossible to utilize families as part of our healthcare team. Due to lack of information in the trauma ICU waiting room, families feel uninformed, needs are not being met, and stress levels are rising before even entering the unit to see their loved ones. Our families spend long hours, even days, in our ICU waiting room to be close to their families and loved ones. The comfort and support families feel in the waiting room is correlated to both their satisfaction and their perception of quality of care. I expect to see improved satisfaction scores through improving communication, improving comfort levels in the trauma ICU waiting room with appropriate amenities, and decreasing stress levels of family members and visitors by providing knowledge and improving communication prior to their arrival into the ICU. After developing my aim, a written proposal using evidence from literature was sent to my unit manager, my critical care nurse educator, and our clinical nurse specialist. Together, we became the team to implement the changes needed. Meetings were held approximately every 2 weeks on the unit. I developed proposed changes using evidence from literature and recommendations from fellow nurses on the unit. 3 measures were developed to assess the changes made. First was a pre- and post-change survey using a Likert scale. Second was Press Ganey reports on satisfaction with communication. And third, we would utilize nursing staff to evaluate families and visitors' satisfaction with the changes and changes in stress levels when entering the unit. Although the change project got off to a great start, activity was halted to prepare for the arrival of JACO. Had we continued, we would have implemented a few of the proposed changes at a time. We would have evaluated the changes using pre- and post-change surveys, the Press Ganey reports, and nursing reports. And then we would have made more changes as needed based on results of what did and did not work. Changes need to be made to improve overall satisfaction, including comfort and communication in the trauma ICU waiting room. An idea to improve continued flow in this change project is to include family or visitor input on changes needed. Once changes are made and show improvement in satisfaction, changes will need to be implemented through written policies, training, and hiring. Next, we would want to spread the change to the burn ICU and medical ICU.